And then for traveling, it is always an issue, depending on where you're going. But if you have access to drinking water, just that bottled water is perfectly fine for irrigation. If you don't think you're going to have a fluorinated source, drinking water, most like third world countries will have plenty of bottled water because that's what most people drink. And then you can just use that for your irrigations. Yeah, the masks are, it's a little bit of a draws attention. Some people are uncomfortable with it, but I have some patients that say, I don't care. And especially if you fly to Asia, or you live in Asia, you work in Asia, everybody wears a mask. Whole Asia, that's, after SARS, that was just everybody wears a mask. Right. So it's a little bit of just your own comfort level with that. But actually, I think for some patients, it can be very helpful to wear the mask.
What's the typical recovery then? Because most GI solves rapidly. So can you recover in like 2 or 3 days, or what is your typical recovery for sinus surgery?
Oh, for surgery? Well, it depends on what your measure is. So if you're talking about just how the patients feel, we usually recommend a week off of work. We do almost all of our cystic fibrosis sinus surgery as an outpatient now, as you know. So, it used to be like 10 or 15 years ago, you have to come in the hospital, you got a medical tune-up. I think we have a much better handle on how to prepare patients for anesthetic. So as long as patients have reasonable pulmonary function and are not acutely exacerbated, that can be done as an outpatient. So I would say 90% of the CF patients will go home the same day. So I think that also improves the time to functional recovery. When you look at the sort of at the healing level, it's probably going to take weeks, probably take 4 weeks or longer. And that's why we see patients frequently postoperatively, because I want to know how your sinuses look after 1 week. If it still looks like there's a lot of pre-existing infection, I might prolong the antibiotic treatment. I might start to use topical therapy earlier in therapy so I don't see the recovery that I'm looking for. We might have the steroid irrigations early. So we'll typically see patients about 3 times in 6 weeks post-op, and perhaps even more for some of the CF.
The reason why I ask you is a lot of times on our lower lung function of less than 40%, we'll preempt them with a CF admission and then tail on your surgery.
Too, yeah.
And then our question in our mind is, when should I have them back for a PFT? And I didn't really know what would be appropriate regarding exertional on a surgery site.
That can be, there's not really a lot of concern for that, maybe after the first week.
Okay.
But
so
in terms of the optimizing, to get a truly get a sense of whether there was improvement or not, I probably would wait 4 weeks, 4 to 6 weeks. Yeah. Because you may still be seeing some effects of, the anesthesia, and maybe some relative atelectasis or lung collapse during the surgery. You may have a longer period of time for the lungs to fully recover from that, not just the surgery itself.
Regarding their anesthesia, is that something that they're put to sleep on, or are
yeah, general anesthesia.
That's a follow-up question about your study, the retrospective study on the effect of sinus surgery on lung transplant patients.
Yes.
It's a very surprising result to me that it didn't seem to change outcomes and that there was rapid recolonization. And I wondered, you gave some reasons why you thought that might be, and I'm wondering if that's progressed anymore. Has there been any attempt to more thoroughly clean the sinuses or anything like that?
Well, yeah, I think, we were kind of surprised too. And when I used to practice in Oregon, and we would do the Stanford protocol, which was basically that everybody who was considered as a candidate for transplant should have their sinuses surgery first. And when I got here and I actually looked at what the paper was, it was actually an opinion paper, and it was about 2 columns, half a page. And that was the Stanford protocol. And that's why we did the study, because we felt like it wasn't really evidence-based. And so we borrowed from these different databases, as you've read the paper, and that's what we found, is that the colonization is rapid. And I think it's just the fact that no matter what you do to the sinuses, you're going to have colonization. So you can reduce the load from, let's say, 10 million bacteria to 1 million bacteria, but you still got 1 million bacteria that are calling that home. And it's sort of intrinsic to just that airway surface liquid that I talked about, and the fact that it just remains a very friendly environment for bacteria to live in, because there's a nutrient source, they're not being pushed out, so they can set up shop, and that is more about why the colonization happens in the lung, rather than we didn't get it all out. And so it's a little bit disappointing, but actually it's also a good thing, I think, for patients, because when we stop focusing on the sinuses as like why patients get colonized, we just accept the fact that they do, we actually subject patients to much less risk. Because if you think about, if you are on the transplant list, you're at much higher risk for a general anesthetic. And if we force patients to have a 3-hour sinus surgery before they can get to transplant, and it's actually not going to change the outcome of the colonization, that's an unnecessary risk to that patient. And so right now, we don't do that at all, unless we really feel like the lung function is compromised because of the sinusitis. And we can see that the patients observe that, the pulmonologists observe that. Then we will go and do that, whether or not the patient's on the transplant.
So I guess what's I'm really curious about is that these are now normal lungs in this patient.
Yeah.
Do they remain colonized with some lungs, or does that get cleared?
I don't know.
Yes.
I don't know the long-term fate of the mucosa and to see whether or not it converts to cystic fibrosis type.
No, it
mucosa.
doesn't do that, I know that.
But I don't actually know that, so I can't tell you.
When you think about a CF exacerbation, it is oral nebulized treatments that penetrate at a high percentage, right? Toby's a high percentage that penetrates the lungs. But then it's also a systemic infection of which you are bloodborne, and it's given IV antibiotics. So in reference to your question, I would think that you would still retain it, although it may not be in your lungs. I think it's retained in the nervous system, and I'm almost positive that the people still grow out these types of organisms of which they are treated. The biggest problem with transplant is that you've been immunocompromised because it's not the lungs. And so your immune system is so far behind the non-transplanted person that they become sick quite quickly, and it just takes longer for them to get better. That's been my experience with the transplant population, whether it's not or some things. That's the biggest one. Do you have somebody that has transplanted or moving into that state?
Nope.
So I'm going to pause at this point to say thank you to our speakers. Thank you so much, both of you, for coming, for the gift of CFRI, these terrific bags, just to say a token of acknowledgement for your time. And I'm thinking if you could stay around for 5 more minutes as we break, Mary's going to be handing out evaluation forms. These are very important to the development of our program. And so as she passes these around, consider our school refreshments home, and do check this table for information on more of the programs that we offer at CFRI. Thank you very much for coming. Thanks to our speakers.
Thank you.